Good evening, everyone, and welcome to this meeting of the Health and Adult Social Care Overview and Scrutiny Committee. My name's Patrick Canavan, and I'm going to ask the Democratic Services Officer if she would be kind enough to read out housekeeping notice, please.
Thank you, Chair. Please note that this meeting of the Health and Adult Social Care Overview and Scrutiny Committee is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. These meetings may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chairman in case of disruption. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the surface car park at the front of the Civic. Finally, please ensure background noise is kept to a minimum. Mobile phones and other devices are turned off or switched to silent for the duration of the meeting. Thank you.
Thank you very much. Do we have any apologies, please?
Yes, Chair. We've received apologies from councillors Farr, Gillett and Matthews. And Councillor Claire Waite is subbing for Councillor Matthews this evening.
Thank you very much. Welcome, Councillor Waite. Thank you very much for coming. Nice to see you. And I have to extend belated apologies to Councillor Moriarty for not welcoming her to her first meeting of the Health and Adult Social Care Overview and Scrutiny Committee the last meeting. I'm so used to seeing Anne-Marie at meetings elsewhere that it seemed like just another day. But so apologies for that, but very welcome to the committee. So any declarations of interest, please? I know we have to do this every time, but just go around if there are any declarations, please. Councillor Salmon.
I work for Dorset Healthcare. I have to say that, don't I?
Yeah, thank you. Councillor Allen.
Yes, I work full-time for University Hospitals Dorset. Thank you.
Thank you. Right, we're going to move on to the confirmation of the minutes. These are the minutes of the meeting held on the 20th of May. And I just ask if everybody is content to accept those as a correct record, please. Everybody happy? Thank you very much. And you'll also see that there is an action sheet. So again, unless anybody indicates, I'll take it that everybody is content that's an accurate reflection of the actions from the meeting. Okay. Okay, so do we have any public issues, please?
There are no public issues, Chair.
Thank you. In that case, we are going to move on to the first item on the agenda. And I'm going to take this opportunity of just asking officers to keep any presentations brief. That sounds really cheeky, but you know what I mean. So this is a fairly significant paper, and as colleagues will know, it's due to go to Cabinet this week. So one of the things we're being asked to do is to report any findings, views, comments to the Cabinet meeting when it meets later in the week. So thank you, Betty. Thank you very much. Oh.
Yes, thank you, Chair.
Sorry, Gillian, that's my apologies.
Not at all. Not at all. We shouldn't sit across the table from each other. It makes it confusing. Yes, I'm Gillian Kay, Corporate Director for Wellbeing in BCP Council, and I'm going to very briefly introduce the paper before handing over to Betty and Phil. As the Chair said, this is a paper that's before Cabinet on Wednesday, with some recommendations for them to consider and to consider taking to full council. It's a paper bringing forward a business case for transformation of our services in adult social care. It makes a recommendation that we, following a piece of work we called the Sprint, a really intense piece of work since the start of this year, that we establish a formal programme which we want to call Fulfilled Lives. And that will be a programme that really shapes our work in adult social care over the next 3 to 5 years, with a whole set of different themes that Betty and Phil will briefly talk through. It is a piece of work that requires investment, and there is an ask of investment going to Cabinet and for Cabinet to consider recommending to council. I also wanted to draw to your attention that there is a specific recommendation in there for Cabinet to consider, inviting this committee to spend some time scrutinising the programme of work. We do consider it to be a really significant programme of work, and we talked in the forward planning session quite recently about the fact that that might be something that Scrutiny wanted to do, but Cabinet has a recommendation to formally invite you to do so, and you might want to consider how you'd like to approach that recommendation yourselves. So that's all I want to say. I'll hand over to Betty and Phil, as I say, to briefly introduce you to what is a really, really significant piece of work with a number of different themes in it, and then we'll be very open to hearing your questions. Thank you, Betty.
Yeah, thank you, Gillian, and thank you, Chair. Just to reinforce that this is the programme for adult social care fulfilled lives, and this programme will be over a period of years if it is approved and signed off and able to be implemented. But I would just remind members and just reinforce that, as you know, 3 other papers that we've brought, adult social care services locally and nationally have faced significant challenges in recent years, and currently today we continue to face those challenges with ageing population, increase in demand, increase in complexity, and as a result we hold significant risk. And in order to manage those and fulfil our statutory duties, we have sought some support from the LGA, the Local Government Association. They came in to support us last October 23. We invited them in because we wanted to learn. We wanted to see where can we do things differently? How can we bring that change about in a positive way? Bring our staff and our residents with us, and how can we have much better outcomes for the people that we serve? And also, how can we empower people to be able to manage their needs with our support, rather than us coming in and feeling like we need to take over. So we did lots of benchmarking, we did lots of work with the LGA, who were excellent in supporting us with that. And as such, we have come up with, as you'll see through the papers, a lengthy, detailed adult social care transformation plan to be implemented in phase stages and up to the next 3 to 5 years. And within that, it is all around how we can sustain the change year after year and then manage that within adult care. I would just like to reinforce as well something that I've reinforced before to the committee, that fulfilled lives is around how we work with families, how we work with our friends, their community, how we work with people in their own environments, in their homes, whatever that home might be, and fundamentally how we keep people safe. That's the key umbrella, if you like, around fulfilled lives. And also linked to that is the national work that goes on in Social Care Futures, which we have signed up to, as you'll be aware of as well from previous papers that I've brought to committee. And that is that we all want to live in the place that we call home, with the people and the things that we love, in communities where we look out for one another, doing things that matter to us. So that's from the individual's perspective. So just leading on from that, I think what I wanted to draw your attention to, trying to be very brief, and I know that you'll do the diligence in reading the very lengthy document. I would suggest that you look at the 4 key areas within the document that are the key priority areas for focus of the whole transformation plan that's going to be happening within adult care. And they're broken down into how we work, which is about our first response service, our conversational approaches with individuals, rather than jumping straight to an assessment and starting to go in there and make assumptions that people have needs. It's about hearing their stories and understanding their journeys. It's about technology, and it's about enabling those individuals that are able to do self-assessments by giving them the technology and us being able to implement that technology to do that. For instance, having a portal where people can log on onto the adult social care site within the council, and that they can begin to populate their assessment, populate their financial assessments as well. Like, most people will probably welcome that. There will be some people who that might not be feasible for them, or they may choose not to. Though any people will be fine. Nobody will be excluded. We will have other alternatives as well. So I really want to emphasize that. And then it's about, how do we define early prevention? Prevention is key to this, and to getting in there as soon as we can rather than waiting. So it's about being, rather than being reactive, it's about looking at that whole preventative avenue and how we go down that. The other areas, so that's how we work. That's one of the key areas, and we've started that work, but have a long way to go. Better short-term support. It's better short-term support. It's about how we will explore reablement options, how we will explore and give access to intermediate care, how we'll look at the quality of those services, and Phil will talk a little bit more about some of that. And then how do we define our future needs, and looking at how we work with others, you know, our providers, etc., others around that. And then the other two areas are self-directed support and support at home. And again, I know that Phil's going to touch on some of that around what is our community offer to people. How do we enable people to have personal budgets to manage their needs, and what does the market allow for those people to be able to have access into? So I think that is probably all I wanted to say, other than to just draw your attention as well to page 21 on the document, where it's on point 10, where it gives you some information just about the increasing demand that continues to come into adult services. If you look at A, B, and C, where it explains the increase that we've had 23-24 and people coming into services. We need to do something different. We need to have a step change. We need to have the time and the resources to be able to do something different alongside the very busy workloads and busy demand that keeps coming into adult social care. And, you know, just point out to you on page 21 at the bottom, it just shows you some of those statistics that are there in the national arena, because that they form part of our SALT returns, our short and long term. That's what SALT referred to as the national term, and that's our reporting of nationally, and that information has been reported up nationally as part of our SALT returns for the council. So without further ado, I'm going to hand over to Phil, who's just going to go into some of the detail that I may have alluded to, and then as Gillian so very happy to take any questions. Appreciate it. It's a very big document. Thank you.
Thanks, Betty. And I don't want to spend too much time, because you will have seen the paper, but you may have questions around some of the detail that we can pick up when we get to that point. And the better short-term support that Betty referenced and reablement, we know that when compared nationally, we do okay, but we could do much better. We don't get enough people the support, the interventions they need, either on discharge from hospital, or more importantly, before they get anywhere near hospital, to help them remain independent at home for longer. And when we move into the Tricuro report, we'll hear from Tricuro about some of the things they're doing to improve that as well. We do, when you look in the document, you'll see, if you look into some of the detail, that we spend a lot of money on long-term care, but conversely, we spend quite a relatively small amount of money on short-term interventions. And that's that link. But if we spent a bit more on short-term care, we can save more in the longer-term care costs that we currently do by promoting that independence, getting to people earlier, and that early intervention can lead to a reduced longer-term need. So that's the better short-term support element. The self-directed support, and sometimes this confuses people. This is about people taking control of their lives. And Betty referenced how we have conversations with people to understand their story before we jump to, and this is what we'll do to help you. So we need to really understand first what is it they can do for themselves and others can help with before we plug the remaining gap. And our traditional model of care doesn't really help with that. So we buy home care,
we buy daycare, we buy residential care. All important services, all part of the wide range of services we need to provide. What we don't do is offer more community options where people can use money themselves, either club together with others or as a direct payment to access community support that might help them in their independence journey, so that they're really not relying on someone. And if you need personalised care where someone helps you get out of bed or get washed, dressed, then absolutely you should get that. But other things, sort of help with shopping, help with accessing community facilities, we can do differently, and we can do in a more personalised way. And then finally, the supported home. So currently our home care model particularly is one that we've had for a number of years. It was brought in 2017, and it wasn't a lot different than the model we had from 2014. So this is a chance to review and re-energise that model, work with our providers, but also work with people to understand what's the right model for them, what would work better for them. And we have a lot of people who access under 10 hours of care a week, and actually that's not a lot. And are there better ways of supporting them that would still meet that need, but don't have someone coming into your home once a day or twice a day just to prompt you around your medication or just to check you're okay? Can we do it differently? Is that where the care technology comes into play and supports them differently? And because currently we support about 41% of the people we support receive less than 10 hours of care a week. Nationally, the best evidence and the best practice would say that should be nearer 15% of the people you support. So we do have some work to do, and we have a journey to go on, and this is the transformation program is the vehicle to get us on that journey and move us into a more modern service that's best fit for the future. Thank you.
Okay, thank you very much indeed. I'm sure there'll be lots of questions. I've got a list, but I'm just going to ask if any of my colleagues want to ask any questions. Councillor Richardson.
Yes, I just wanted to ask, I'm a little concerned, is the ultimate objective to reduce the opportunity for sheltered and residential care for people? I have first-hand experience of this with my mother, so that's what concerns me.
No, it isn't. What the journey we have been on, and if members may recall that we issued an extra care housing strategy that was approved by Cabinet back in 2022, that was to use not just sheltered housing, but sheltered housing with care on site, so that you still remain in your own home with your own front door key, but actually the care comes to you. It's a big jump to go from living in your own home into residential care, and there are steps in between that might be better for you individually. There will be people who still need residential and nursing care. It's making sure that we have the right response for the needs that are presented in front of us, rather than having very limited options of stay at home with support or going to residential care. Sheltered housing with care going in is a bit limited because you might get 2 or 3 visits a day if that's what your needs suggest, whereas extra care housing has a 24-hour presence on site that can respond to issues and emergencies in a different way. So it's about having different models at play.
Councillor White.
Thank you. Phil, what you were saying earlier about, I just want to make sure I've understood it correctly. I don't think I wrote it down right, where you said where people sort of go into hospital and then they come out and the care isn't there, and we sort of have suddenly put something together. Is that sort of correct sort of summary of what you said? And then it sounds like what you're aiming to do is to kind of be a bit more sort of proactive, sort of recognise at-risk people, and but then you sort of went on to say that, you know, some of this could be sort of self-directed community support, and I kind of think, well, nobody anticipates going into hospital, and if you've just come out of hospital, then you're not going to start getting together with your neighbours, and then that was where, for me, my understanding kind of broke down. So wherever I've just sort of not understood, can you just go over that again, please?
Yeah, probably because I spoke quite quickly about a range of things. So if think about someone who's been in hospital and who wants to go home, return home, quite right, that's what we want them to do. The short-term support is about enabling them to regain the skills they may have lost through that hospital stay, or to recover them functionally. So they may have had a stroke, they may need to recover some of their functionality with a physio or an occupational therapist supporting them, and just giving them space and time to recover before we think about the long-term support they may or may not need. And what we want to do is to increase the ability of our reablement function to get in there and support people. Currently, we're not supporting enough people well enough to remain in the community. The other side of that is, before you go anywhere near hospital, you may be in your own home and things just aren't working as they were. You're starting to lose a little bit of your functionality, or you may become forgetful. Reablement can come in and work with you to regain lost skills or gain new skills. You may have been recently widowed and you didn't know how to cook or clean as well. Help you gain those skills. So there's a range of things that we could do, and I just wonder whether Betty or Tim want to come in and just build on that.
Yeah, I think it's a really good question. So I think just two things on that. Just going back to your point as well, and just to add on what Phil said, it is absolutely not about having the same options available. It's about having a better range of options. That maybe we don't have some of those at the minute. And I think what I would say on residential care, it's about people going into residential care if they need to at the right time, not prematurely, or not prematurely, but also not further ahead to what they should have, not delayed either. It's about getting it at that right time so that it's the right environment for that individual. And I think that's what's critical. I see a lot of people who've gone into residential care because of a crisis and because of a situation. And had we been able to prevent that crisis or reduce that crisis or get in there sooner or know about that crisis, the build up to that crisis, then we may have been able to do some stuff differently. And that's where the whole prevention and almost case finding comes into play. And then just on your point, discharge is a very broad topic in itself. And having worked in hospitals and done a lot with our hospitals on a daily basis, there's lots of entry points and there's lots of exit points, and you've got to get it right for that individual at that time as well. But I think the fundamental thing that Phil said, and what I would just build on, is you need to have a recovery model. People should not be having their long-term needs decided when they're in an acute stage, because what you will either do is you will over provide, so therefore you are making them dependent rather than empowering and creating independence, and that's not right. But it also isn't the right environment, and you don't see people in their true selves whenever they're in a hospital acute environment and they've had whatever that episode might be. So it's about having a good, sustainable recovery model, and that's the work that we're doing as a system with our health and community colleagues, as well as looking to embed that within our programme of fulfilled lives within adult care. Thank you.
Councillor Dedman.
Yes, thank you. It's a really good paper, considering you sprinted at it. I think it really, really good. My question was going to be about reablement. One of the things is, do we pay for all that reablement, or does somebody else do it?
Reablement generally is a free service because it's classed as intermediate care. So for a period of time, usually 1, 2 or 3 weeks, but up to a maximum of about 6 weeks, we can support someone to recover, and that whether that's health or social care does it. Yeah. But you're going to say something else.
I was going to say, does the council pay for the reablement worker to go and help able the client?
Yes, so we fund the that care and support, that enablement, reablement support. That's part of our, and that's that's recognised in part of the Better Care Fund that we receive, which is money that comes down from NHS England.
Okay, but my other question was on, I think it's on local and national drivers for change. You mention that local government funding has failed to keep pace with the increased level of demand. Is there going to be any change in that, do you feel? That are we going to see, or indeed are we asking for?
It feels too early to say. I'd like to hope that it will. There is certainly the need there and all the evidence there of the need, but I think it's too early to say what the direction of travel will be. And whatever happens, there are financial drivers for change under this business case. That's very clear. Even if there was all the money in the world, which there won't be for adult care, there are changes in here that we would still want to make because our services aren't as modern as they could be and as preventative as they could be and as empowering as they could be. So yes, there's a financial driver, but the real driver for us is that fulfilled lives aspect. And then let's see what happens with the finances.
Professor Moriarty.
Thank you. I'm afraid I have a bit of a list as well, but I'll only ask 2 or 3 from it, if that's okay. Within the whole, it was a really thorough report, and I think the idea of prevention rather than intervention at a later stage is absolutely the way to go. And I think that 3 conversations approach is also a really good idea, because you don't want to make long-term decisions when somebody's acutely unwell. There was a couple of things. I didn't notice very much about carers, and we know how fundamental carers are and supporting carers in order to continue for people to live at home. And staff. I appreciate that. I'm sure here is no different than the rest of the country, and actually social care staff are like gold dust. They're very hard to get, and generally speaking, their pay and conditions are quite minimal. I'm just wondering, is there any provision in this to improve the pay and conditions of staff, to improve the kind of carers allowance, just to kind of enable all of that to move forward?
If I'll start on carers and then bring Tim in, because Tim leads from an operational perspective on carers services. So we revised the carers strategy. Was it last year we did it, Tim? Or the year before? 2022. In about October, November, we took a report to Cabinet, refreshed our carers strategy and talked about the support and how we would. Some of it was building on what we already did, because we do reasonably well with carers already. But what more could we do? How do we enable them to take breaks when they need to take a break? How do we think of the services that would support them so they can still continue in their caring role, but also step away and feel confident that whoever's going to support their loved one for a period of time, even whether it's a few hours or a short break away. So we do have that, and there's funding that's built in. I mentioned the Better Care Fund before. There's some dedicated funding that goes for carer support, but we also, as a council, invest in carers. So they're a very important part of our whole model of care is how do we enable it, because a lot of people still want to care, but just feel that sometimes they become too tired to be able to do it. And so what can we do? And some of it's about advice, support, mutual support with others. And I'm going to stop there and let Tim come in, because this really is his area.
Thanks, Phil. Yeah, it's I think the key point is that with carers, particularly, I was really glad you mentioned the 3 conversations approach, because that applies equally to carers as it does to anybody else. So really listening to carers and understanding what it is that's most important to them, and making sure that we actually tailor the support around them is really important. Phil mentioned the adult social care carers strategy, and we know that one of the key priorities within that is actually about making sure we're identifying more carers. So although we've probably got around about 7,000 or so carers registered with our carers information service at the moment, we know that the national sort of statistics is around 1 in 5 people are and unpaid carers. So given the size of our population, we know we've still got quite some way to go to make sure we've reached out to as many of those carers as we can. But the 3 conversations approach is very much about trying to get in early and understand what's important and provide that support in a preventative way as much as possible to support people.
Do you want to ask another one while you're at it?
Supplementary, just about the staff and staff conditions and pay and retaining them.
So shall I take that one? Yeah, so with regard to the social care carers that go in and provide care, I think that's what you're meaning. Yeah, domiciliary carers. I think the living wage has gone up. I mean, it's never going to be enough. You know, it's never going to be enough, and you know that's recently gone up. But I think it's that whole umbrella around valuing carers, valuing the job that they do, allowing and giving them access to come in and have access to training. It's around how do we work as a health and social care system within the Dorset area to really value those carers. I think the kind of national, looking at the national setting of the minimum wage or the living wage that you can pay, you know, there's been some progress on that, but you know, it's not enough for the recognition of the job that people do. And I don't think that there's anybody in health and social care that would say different to that. It's around you know, how do we work to keep those really good carers, and how do we work to make them feel part of the health and social care system within our area, and how do we, for me, I guess as well, it's about how do we really get in there early with students, then how do we give people opportunities, how do we build on how do we make sure that our workforce strategy really reflects this. I mean, it is within our workforce strategy, but how do we, you know, really draw that out, and how are we using our apprenticeships route and all of those stuff, because it is about financially people being able to live and being able to be able to look after themselves and their families. But equally, it's also about satisfaction, career progression, feeling valued, feeling part of a team, feeling part of the whole kind of multidisciplinary team. And I think there's still some way to go. And nationally, I think groups like the LGA, ADAS, carers associations, all those kind of forums are constantly lobbying government on these particular areas around fee, you know, the cost of well, what we pay our really valued carers. But I don't know if Phil wants to add anything to that.
The only thing I'd add, that there have been calls for councils to pay the real living wage, and whilst I would love to be in a position to recommend, and I could recommend to council that they do that, it's the financial impact that has, and how we then, and this comes back, I guess, to the question that Councillor Dedman asked earlier about will there be a change in national funding with the new administration? We don't know yet, but just for example, the recent increase in the national living wage that we incorporated in this year's budget added £12 million to the council's bottom line, and that had to be, so that means something else has to give if we've got it. And it's the choices that we want to make as a council, isn't it, of where do we want to invest any money that we do have, and what then gives somewhere else. But that lobbying of government is around, let's get a fairer wage for care workers. So how can we do that? I think lobbying's our best chance at the moment, and we'll see what the new government announces probably in the autumn.
Sorry, just a final clarifier. So are we only paying staff minimum wage at the moment?
In
domiciliary carers?
In the external workforce, most providers are paying above the national minimum wage or the national living wage, and they're doing that to attract people from other things like hospitality, retail, leisure. but that's within what the council can afford to pay them, or their private funders can afford to pay them. We did a fair cost of care exercise, which identified what we should pay in order to pay a reasonable return to the provider while still securing the right level of staff. And we're pretty close to that. We've worked on it for a couple of years to get to that level. That means on average we're paying about £25 an hour overall to providers, of which by the time they pay the staff wage, national insurance, pension and allowance for sickness, etc., training, that leaves them with a small profit, probably at about 3%. That's their general level. That's what's factored into some of these national models.
Okay, a number of hands. Can I take Councillor Salmon next, please?
So I think Anne-Marie's touched on it. I think one of the big problems I think we face as a council is we've sold off our kitchen, you know, and all the utilities in there, and we've just been ordering takeaway for the last few years. We don't do anything in-house anymore. And I just wondered if there was anything within this strategy, within this transformation plan, that would be looking to remove that reliance on the third-party providers.
Not specifically, but the investment we have in our own care company is the council influencing the market by having Tricuro in place. So that's a council-owned company as opposed to an independent provider or a commercial provider that's there for profit. And that allows us, we want to increase the influence that our care company has on the market. But that will require investment over time to get there. So that's a sort of an indirect response. We do have some directly provided services within adult social care still. And I don't know if Betty, if you wanted to touch on that.
So yeah, I just wanted to pick up on just the Tricuro, and we do have one of our colleagues here who's gonna talk about that. And in the paper, it does talk about prevention. And it does talk about building on reablement, and that's where we want to really look at how do we get the best use of the reablement resource that we have, but how do we build on it as well? Because ideally, what we would really love to get to, and I'm sure councils, you know, all councils would like to be doing this. Some may be already doing it, but I know that a lot aren't. Is to actually have a mechanism where nobody goes into any long-term care provision, be it home care, be it residential, be it whatever kind of care that might be, until they've had an offer of reablement. Reablement should be a default position. If you have a need or if you have changed, either through a hospital admission or through, you know, a deterioration in your home, in the community, and you need some support, that is a really good way to assess. And there's a lot of national evidence that tells you that if people have reablement and intermediate care where that's needed, rehabilitation, and if they have it in the environments that they're used to, so they're not going into different environments, then their longer term need after they've had that is usually reduced, and it allows that person and their family to regain that independence and that control and that empowerment. So, Councillor Salmon, when you're talking about, are we going to invest and bring more things back in the house, I think what we need to do as part of this is really build on what we already have within Tricuro and really use that to meet the needs that we know we have, and for the people that live in the BCP council area.
Okay, I'm going to take Councillor.
Super quick. Can I just follow up on that? Because there was
Through the chair, you can.
Oh yeah, through you, Patrick. Can I follow up on that super quick? So I might have missed it in the forward plan, but is there a specific target for the percentage of work that Tricuro is going to be picking up relative to the other providers? Is the idea that that will grow?
That's not within this transformation plan. No, that's not the thing. The commissioning elements of what we commission and how we commission it be picked up in different cases or business cases, how we want to develop further the options we have around TriCuro.
I'd like to very briefly comment on your mentioning of training. I do think that people that work within social care in the community do deserve to be respected and appreciated more by the whole of our community. And I think training is a big part of that. I mean, I would like to see getting everyone to a level where you could actually go and do a shift in a hospital or a shift in a care home or go into someone's house and have the same level of skills and care so that you would feel valued across the board. And I do think we do need to work much bigger as a system. So that's just a personal view. I just wanted to go back to your point about the fact that you have a lot of people having fairly low level amounts of care. And I think, have you sort of unpicked that yet? Because so there's one bit of me that thinks, well, in one respect, is that not good? Because that means you possibly are keeping people in their home environment with a fairly low level of care. But is that actually that's just because families like it, because it makes them feel safe that their relative is safe? And do you have any plans about how you could reach out to, say, organisations, charities and so forth, who could perhaps support people more, where they don't necessarily need a physical carer, but they need to feel connected to people? Because I hear you talk about technology and I get it, but then a lot of that is about just seeing a body and a person to come through the door and to feel like they're still connected to their community. So I'm just interested in how you've sort of thought about that, because in one respect it sounds, you could do something more with that. But in another respect, there's a bit of me that thinks, well, that's possibly quite a good thing. So I'm just interested in that, because it is a interesting factor that 41% of people are getting low levels of care. Thank you.
Thank you, Councillor Allen.
Do I have a question that's very closely related to what Hazel said, so it might be efficient to link it in, if that's okay? Thank you. Yes, it was just because you said that the LGA pointed to a national figure of 15% of clients who get less than 10 hours per week of care. So I was going to ask a similar question to that, but also ask why that is, and are we assuming that we can get that 41 down to 15%, but are they actually comparable groups of people? I hope I haven't derailed your question, but I felt they were related.
Here's what I want to say thank you, because you actually picked up something I should have said at the time. So it's not to take away, we recognise there's some level of need in that 10 hours or less. It's how you meet the needs. So technology might be one thing that helps, but you're absolutely right about working with voluntary and community sector about can they offer a better value option of working with people within and around their own communities to support them, whether that's to support them to do shopping or some domestic tasks or just friendship groups and removing social isolation, which helps their mood and keeps their independence. Because one of the big things is if people become depressed or low mood, then they start not to look after themselves, and then that triggers and we end up in a crisis situation. So thank you, because I should have said something along those lines when we were talking about that. So it's to do something different. If there's no personal care requirement, then actually we don't need a regulated service, such as a home care service, to deliver it. We can have alternative methods. And that links in directly to your question, which is, it's not saying it's about who receives home care, which is a regulated service, and that 15% means that people will be receiving some alternative type of support that meets their need without them having a regulated service going in. We need to protect and use our home care workers for those people who have the highest level of needs, so that we can maximise the benefit.
Let me just take Louise, and I'll come. Sorry, Councillor.
Just ask one very quick follow-up question. Within this sort of transformation and what you're looking at, is there an opportunity just to revisit what people need? Because I think the problem is that people get stuck in a care offer, and no one's, because goodness, you've got so many people coming through the door that need care now and urgently and leaving hospital. Are you going to have an opportunity to sit down with people and go, do you know, does this fit what you really need now? Because we may well be giving care that's not needed. Thank you.
Yeah, I think that's a really good point too, and that is fundamentally what the conversation approach is about. the conversation approach is broken down into a number of conversations, and the conversation one is about exactly that. It's about having that conversation, unpicking it, and then coming to an agreement with the person, which won't always and should not always be about care, physical care, but it could be about how to introduce people into different things. As Phil said, personal care and care for the person is completely different. And you know all this, it's completely different to kind of well-being overall. It's part of well-being, but it's not, there's other elements to somebody's well-being, and that is exactly what the conversation approach is about. And we've had a national partner in to really do that work with us. We have done so much work around this business case. We've tested some of the approaches. We've looked at national benchmarking. We've brought in the LGA. We see this as the future of adult social care within the council, and we have to get it right, and it has to be sustainable. But if it's okay, Chair, if I can just touch on the 15% and the 41% of the hours, I think what I wouldn't do is get caught up on the number of hours that somebody actually needs. There is some discussion, and there is some a while ago about national conversations around if you have under 5 hours care, structured care, are there different ways of delivering that? What I would say to you is I see people who have got 10 hours a week care, but that care is still quite intense. It is still necessary, and it might be that they need that care in the morning, but they don't need it at night because their partner is there, or they have other ways of having that care done for them. And I'm not saying the carers should pick up any slack, but what I'm saying is people make arrangements that suit them, but I wouldn't get too caught up in the actual numbers of what people physically have, because then we have the other end of the spectrum where we have people that have huge amounts of care because they need that, they have no other resource. So it's important to pitch it at the right level for that individual, whether it's 7 hours a week or whether it's 27 hours a week. It has to be right.
Louise, thank you for being so patient. Could you ask your question now, please?
Thank you, Chair. Appreciate it. I think it's really good to read this report and see the focus on prevention, early intervention. And it made me think that I was talking to Healthwatch England just this week, and they're publishing a report on social care at the end of the month, which I'll share with you all. That in that, some of the recommendations they make are mentioned in this report. So it's really good to see that. One of the things they talk about in that is that the people that they spoke to, a lot of people don't know where to go for information about social care, and there are a substantial number of people not getting the care that they need because they don't know where to go and how to ask for it. And certainly we hear from local people who really struggle to find their way through the system to know where to go for help. So I suppose my question was around what will you be doing to raise public awareness, really, of social care, of how to access it, how to get good, clear public information about it. And with the transformation, how will you build in gathering people's feedback to monitor the kind of progress of this transformation programme? Thank you.
May I just answer that question in terms of how does the person at the other end know what, how they're going to see the difference, and what, the point that Louise has made, how are they going to be able to better access that support?
Thanks, Chair. Thanks, Louise. So I think the first thing to say is just in terms of the feedback, particularly the work that we've been doing around our 3 conversations approach and the pilot areas that where we've tested that model. We've taken, as you probably know, actually, we've taken particular lengths to actually get that feedback directly from people that we've worked with, and the feedback we've had has been overwhelmingly positive. People saying that they feel that like they've been much better listened to than they've experienced previously, and that they've actually had some response from us a lot sooner than they were expecting. And again, that I think so we've got those kind of quality kind of measures directly from people coming back to us. The point about people knowing where to go, I think is a really interesting one. It's probably quite a challenge, and I can remember over many years we've had that discussion about do we have a single front door, a single point of contact, or do we have multiple points of contact whereby there's no wrong door approach. And I think we're still working our way through that to some extent. Certainly what we've been doing with the Adult Social Care Contact Centre more recently is undertaking a review of all our web page content, and we're doing the same with our carers online information as well. So we've just rebranded from CRISP to BCP Carer Support, and we're going through that process of, with carers actually at the moment, reviewing the web page content to make sure that it is actually sort of hitting the mark in terms of what people need.
I think there were some other hands, actually. Any other? Yeah, let me take Joe and then come back to you.
Mine was sort of a supplementary on what was saying earlier, if that's okay. It was just that my angle, I suppose, with asking about the are we aiming to go down to 15% for that group is, I suppose I was asking, are the cost savings that we've built into this plan sort of realistic? Because what's going to happen at Cabinet, everyone's going to talk about sort of how cash strapped we all are, and are we actually going to see this return for the cash injection? So I just wanted to explore the assumptions used in the cost saving.
Yeah, so I think the work that we've been doing on the 3 conversations approach, that's been our test, and the people that have gone through that, and that if the staff that have been working in the innovation sites that have been implementing the 3 conversations. Now, we can argue that we've always done a bit of 3 conversations approach, but we've never done it as intensely as what we've done in the innovation sites, which are the areas that we chose to do it in. And within those areas, as Tim referred to, we've had really positive feedback from the individuals that have gone through that. And we've also seen that a higher percentage to normal have gone to not need any care at the end of that, or to have a greater reduction in their longer term. So I guess what I would say is, by really embedding these approaches, that they are the only approach that you would use at the beginning, that they will naturally bring some of those efficiencies through the model changing. This is about changing our Fulfilled Lives programme and really trying to drive it into being fit for the future, but also being sustainable, because we know the landscape is very challenging. It's not going to get any easier. We've got to make a judgment, and we've got to take a risk, and we've got to do this, and we've got to be able to look at what that will bring. I just wanted to touch on the point that was raised as well about the voice of the carers, and I think it was Louise, you were just referring to Health Watch. I was really pleased to hear that that's going to be some of what we've put is going to be coming out in their national report. What I would just let members know is we did some work with TLAP, which is Think Local Act Personal. It's a national organisation, and it's there for the voice of the person. It's there for the voice of the carer. You talked about carers, you talk about the voice of the person and how we engage with the individual. We are really, really keen and consciously wanting to and making sure that we engage and that we get that feedback, but that we bring people in really early, and we have those individuals that have true lived experience and expertise coming and working alongside us to implement this. And we're looking at how we co-produce within adult care, and then how that rolls out into the wider council, because it's really critical that we do that alongside this.
Councillor Salmon.
Just to just to pick up a bit more detail on the financial elements, there's no one element of the transformation program that gives you the saving. It's the combination of everything. So they're all interdependent. So if someone gets some reablement, they may not have any care needs. You might take them away altogether because so that might reduce that 10 hours down to 0 or to less. But it might be that they get some community support, like I said before, or that takes away that. So if you look at it in isolation, just say, are you going to do X to save Y? That'll give you the wrong answer. But if you look at it as a whole, and that's why the 4 areas do work together very well, then that brings you the cumulative savings. So our challenge will be, how do we evidence back, and we've tried to set it out in the report, the different areas where the savings will come from. But if the 3 conversations don't take place and the reablement model isn't strong enough, and we don't have the voluntary community sector alongside us, and we don't think differently about personalisation, how people get what they want and need through their own voice and their choices, then we won't deliver the outcomes that we've set out in that report.
So I've just got one more question, and then I think I'd like to make a recommendation, So a lot of the stuff you're talking about sounds like innovations at scale, where you identify this works, so we'll do it on a larger scale. And one of the risks is with Mosaic software. And I just wondered, with Mosaic at the moment, is that actually, I don't know, I can't remember if BCP Council has a data warehouse or similar, but at the moment, is Tricuro hooked up to that? So you're pulling all of your lovely metrics out and it talks to all the other systems and whatnot. Is that the current state of play?
So it doesn't feed directly into Tricuro, don't feed directly into Mosaic, but we are looking at a provider portal as one of the next iterations or next developments within Mosaic, which would allow them to directly input and also have limited access to details on the system. But we would do that for other providers as well. So it's a really good point about how do we make sure that the data is correct. So Tricuro have systems where they collect data and they have to manually transfer it over in spreadsheets or whatever at the moment. So it is one of the development areas to make sure that we get it to be a seamless pulling of information into that data lake, that data warehouse, so then it can be analysed and spewed out through the standardised reporting that we must do back to central government and for our own performance returns as well.
Okay, I think what I'd like to do now is kind of move us to a position where we're looking at the recommendations and bearing in mind what Gillian said at the outset about there is already in the recommendations in the cabinet paper the idea that they're going to ask this committee to do some scrutiny on the plan. So I've been given some thoughts about how we might do that, and indeed whether or not that recommendation is strong enough or specific enough. So it might sound negative, but it's not intended to be, because I tend to look at these things through the kind of prism of risk. Where are the risks? And you just touched on some of them, haven't you, in terms of how we might try and ensure that we identify those risks early, or if for example, the recruitment that you are going to need, this is very much part of the 2.9 million. It's sort of extra pairs of hands, isn't it, to do the work? If that doesn't go according to plan, if you struggle to, fulfill the procurement objectives, that there are quite a lot of risks. And what's in my head is thinking, okay, that's fine. You know all that's better than I do. But how do we, try and keep a handle on how that is going, and whether that kind of just general look at the scrutiny is going to get us into that level of detail. So that's what's in my mind. Any thoughts on that before I ask Joe if he's got a particular recommendation he wants to make?
I think there are lots of risks, if we're being totally honest. When you look at it, each kind of key area could have risks within that. I guess what I would say is that in the report, there is what we're referring to as a break, and the break is every 6 months to then stop, take stock, reflect. Not a long break. If it's all going okay, and we want to keep the momentum. Momentum is really, really important here. But there does need to be that time to just be able to reflect and see and have that test and challenge around what have we learned over that particular area or that particular period of time. And they are built in. And I think also, just to remind members that in the paper, it refers to the sprint, and there is a 3-month sprint period. And within that sprint, that's whenever we were able to look and test out some of the concepts as well. And that was a really valuable period of time that took place. But those breaks are going to be critical, and we must make sure we take those. And that could be, where ONS have a real key role to play.
Summers, if you want to add something.
Yeah, so I think there are 2 recommendations then that I would like to make with this. So the first is we've got the identified programme risks at the end of the document, and I think it is worth including in there the current lack of a feed from Tricura and the other providers into either the council's data lake or into the DICE, because I think without that, the identification of all of these innovations at scale, they're like, this is how we stop somebody going in, just won't happen. So that seems a really key piece of work that needs to be carried out. Then the second recommendation, do we have to do these one at a time, or can I bang them all out?
No, bang them all out, Joe.
Bang them all out. So next one, I mean, from my point of view, I think actually Tricuro are brilliant in that they don't have the same skimming off the top that happens in for private provision. I would actually like to see an explicit target for the percentage of commissioning that goes to Tricuro, with the idea that that goes up year on year. I'd like to see that included in the strategy as well. I don't know if that's totally inappropriate for this document though, or has to be done in another way.
I'm looking to the expert now.
It's a good point. I think it should really come out of some specific commissioning intention. So we may need to do a commissioning framework, a strategic commissioning framework that says how around adult social care, about how we would want to maximise or enhance. I'm afraid I haven't quite got the words in my head, but I take your point, and I don't, with respect, I don't think it's this programme. I think it's a commissioning intentions programme around how we want to work with the market, and that includes Tricuro and about their influence.
And in terms of Councillor Sam's other point, is it possible to find a formal words to include that within the document?
I think, as I was saying, Chair, I don't think it's for this document. I think it's for a commissioning framework or a commissioning strategy that says, working with the adult social care market, what we intend to do. I'm just looking to Gillian to see if you think that would make, if I'm on the right lines from your perspective.
Are you answering the Councillor Salmon's second point or his first point around the data feed into Mosaic and the DICE?
You were dealing with. Yeah, the data feed one, I think, is the link is the Mosaic provider portal work that's part of the work that we're including within this programme, and what's the correct word? The implementation of the provider portal is within the programme. We could make it more specific if that would be helpful. That wouldn't be difficult to draw it out a bit more.
Yeah. Or could, if it's an amendment to the recommendation that you're particularly looking for, could it be a form of words around recommends that Cabinet highlight that specific risk when making recommendations to Council? Is that the point?
So I think your 2 points were really well made. I think that the one about Mosaic, I think we do need to do further work around that. I think that would help all of us for our reporting. I think what I would suggest on that is that that could be a recommendation, as you've said, for this paper, because when you look at what is within the IT element of this paper, there's a section that's on IT that is about Mosaic. That's about the provider portal, as Phil's just said, and I think the provider portal is the right venue to build on what Councillor Salmon has just said. Because if you look at what the IT stream is under Mosaic, it's the portal for providers, it's the financial assessing, individuals being able to go online and to self-assess, to do their financial assessment and to do their online self-assessment by having those tools available. So they're the three key IT elements that are built within the adult social care transformation plan. And I think your first point lends itself really well to that. I don't think your second point does, as Phil said. I think that's a different paper that could come back to ONS, where that recommendation could be then considered then, and that is about commissioning intentions maybe for 24, 25, 26, 24, 25, whatever that might be. And I think that's what you were suggesting, Phil. Thank you, Chair.
So in terms of the report that I've got to give to Cabinet on Wednesday, we're appreciative of the offer to have a look at the scrutiny, but we're going to ask them specifically if they will look at that aspect of the programme in terms of trying to ensure that the data feed is there and that we're on top of that that information. That's one element of it. And I think the other element is also to ask if we can find a way of taking advantage of the breaks that Betty's referred to, the 6 months breaks, to ensure that we do keep this under a kind of more rigorous review. Does that cover the points, Jim?
Yeah, I think that covers the points. I get the second thing doesn't fit, and it sounds like you've got a handle on how to do the first thing. Cracking.
Okay, well, we'll tidy up a formal words before Wednesday, but I hope people feel like that's generally supportive of that. Councillor Allen.
It may be within the report, and I've had some issues with ModGov this week, so I haven't been able to look at it as in details as I would have liked to. But it would just be really nice to have a list of what your key risks are and your key performance indicators are that we could then use and have, and then possibly look at with you when you're doing these breaks. So if you say to us, this is what we were hoping, and it may be cost savings, because I've written lots of investor save cost business cases in my time, and you do have to look at how hopefully your cleverer, better way of working is going to save money, because you can't do it otherwise. So that might be one of the questions, and the other question might be around, you've had some excellent good feedback from your trial people, if you like, but is that you would assume if 10 people are happy when you look after them, that 100 people will be happy, but it might not be. Are there themes coming out that you weren't expecting? So it would be really nice if we just had like a list of key performance indicators, the actions that you're taking around them, and so that we can use that and put that aside to your sort of breaks, because those bits where you get to that 5 minutes to sit, stand back, hopefully, and take a deep breath, be really nice to pull that out. And I think particularly around the carers and the individual's experience, and whether or not, and also your staff's experience about whether this feels good, because it sounds like it makes complete sense to me, but it sounds good, but it's just what's the actual experience, and if there was some key performance indicators and actions around that would be excellent. Thank you.
Julian.
Thank you, Chair, and thank you, Councillor Allen. I think that's a really, really valuable suggestion, and I think that's an extremely useful role that Scrutiny could play, that looking at the data, quantitative and qualitative, that's coming out of the process, working with us to be curious about what the data is telling us, because as I think Councillor Salmon said earlier, this is about genuine transformation, large-scale innovative change. It won't be linear. We're going to have to hold our nerve collectively for the savings to come out. Some things may go up before they come down. Some things may just move around the system. and we need to genuinely be testing ourselves as to the impact of the things that we're doing. And if they're not going in the direction that we want them to, we need to be pausing and reflecting and trying something different. And that's the nature of the programme. But that external scrutiny as we go through that will be really, really valuable to us.
Okay, I think then we've reached a kind of conclusion on that item, and we'll find a form of words for Wednesday to feed that back into Cabinet, so that Cabinet have some idea of what the Health and Adult Social Care Overview and Scrutiny Committee have said. So thank you very much for all of that. I'm going to move on, if I may, to a not unrelated item about the Tricura business case. So, Mr. Hornsby, do you want to start?
Yes, thanks, Chair. But I'm just going to do a brief introduction and then bring Richard Warren, who is from Tricura, to both introduce himself in his role, but then take us through an update report. So, Cabinet considered and approved a strategic business plan, a 5-year plan for Tricura. And just to remind people, that's the care company that the council owns. And that's really very closely aligned to the corporate strategy, but also some of the things we've talked about this evening already. So I'm not going to take any of Rich's thunder, just in case he's going to cover some of the points I've already said. So I'm going to hand over to him and say, Rich, if you don't mind introducing yourself and what you do, and then take us through the progress.
Sure. Good evening, everyone. My name is Richard Warren. I'm the Corporate Director for Tricura, here in the place of Derek Law, who's sunning himself in Mexico at the moment, and is our Interim Managing Director. So as Phil pointed out, I think we just turned 9 in July, our 9th birthday, and things have ebbed and flowed, and we've gone through different states maybe of modernisation programmes and change. The pandemic largely probably got in the way as well, and we've come out of that, and we've really wanted to agree and align our strategy directly related to the BCP Council's commissioning strategic intentions, which is what this paper is largely about, and also the strategy that you agreed some weeks ago. So I gather you've had this and you've probably read through it. So I don't want to sort of take time just going back over old ground. Really interesting to hear the conversation from the first point, though, completely aligned, and maybe it might be right in that we talk about reopenment first, but I'll be guided by yourselves, because it's such a big part of the paper that Phil and Betty were discussing just then, presenting just then. So to get into the weeds of it, we Tricura do want to be at the forefront of the reopenment change that's happening. I think probably the biggest barrier to our reopenment function at the moment is around recruitment. I don't think that'll come as a massive surprise. The detail around that really is, I mean, you think of it, you're an employee, you've got options. You can go and work at a care home, 12-hour shift, you know where you are. You might go on a minibus or some day trips with your residents, and that's all fine, and you can plan your life around that. For reopenment, it's very much you have to own your own car. You do get your petrol money, but it's no single day is the same. And that's a niche market to start with. And then we've got other factors. There are many other providers, the wage structure, et cetera. So Tricura have gone through several formats, I think is fair to say, over the last quite recent years, actually the last couple of years. We've tried to increase the wage, be really clear about what reopenment is, because that's a bit of a mystery out there too with people who are coming out and sharing the system. That it isn't dom care, it's a skill, maybe the next notch up from that, and actually we're trying to support the hospitals in reopening people. So part of this, as you'll see on and off, all of the objectives there are really about supporting that step down from hospital as quickly as we can. And the other service that lends itself very well to that is Coastal Lodge, which I'm sure you'll be familiar with. And this again is a supportive place where we take on clients as a direct step down from hospital. A lot of OT involvement, which Phil already alluded to earlier as well, which I think is an area of growth and something that we'll want to look for extra support on. And so that's really the main focus, I think, of this paper today. Whether you have any questions on that per se, so I can pause, or Phil, if you wanted to add anything.
Did you want me to come?
Just, I think Rich is probably underselling Tricuro slightly there, because if you look through the report, and it's the links that talk about the improvements. They've already got good services, the regulated services. It's about making them even better, and that includes the development around training, the staff development, management, the opportunities. But there's also that link into the wider system. So intermediate care, as reablement is just part of intermediate care. Intermediate care is a much bigger piece of work where the NHS are heavily involved, and how Tricuro can work hand in glove with the NHS teams, so that we really wrap care and support around people in that recovery journey. And the second bit of the reablement journey is the prevention end that we talked about earlier. So Tricuro services at the moment are quite focused on the back door of the hospital, so discharge, and we want to move that so it's more balanced. So a percentage of it's looking into the community to prevent admissions to hospital or long-term care, as I said earlier, but also continuing to support the NHS at discharge. The trick in all of this, and I think Councillor Salmon referred to it about what's the target to keep investing more in Tricuro, is where can we release funding that can further, so you kind of, it becomes a cycle. If you can do more reablement, then you can do less long-term care, because the need is dissipated a little bit, not gone away altogether. So one of the aims is, how do we keep growing Tricuro, but some of that's through the release of monies, not the savings targets, but what's the over and above? How do we encourage the NHS to invest more in our functions? Where is the funding source to grow? And it's also, some of it's about efficiencies. So another part of the plan is around how does Tricuro become more efficient in its operations, that creates the ability to recruit more frontline staff to work in reablement or whichever other part of the service system. And the other key bit is the links into the day opportunities. So this committee has seen and scrutinised before the day opportunities review that targeted what we were going to do to modernise day opportunities. Tricuro, a key element of that, because they also already deliver the majority of our buildings-based services, and it's a shift in a modernisation of their services to blend that with the community support as well element. So, Rich, I don't know if you just wanted to touch on that a little bit.
Sure, yeah, just going back to reablement for a second. I mean, you're right in that it's about Tricuro trying to get under the skin of getting more for your buck, basically. So more contact time with the staff that we have, really scrutinising and planning carefully. And we talked in the recent past about looking at localities in terms of hubs, and that links in nicely with the day opportunities consultation that you went through in the early part of this year, because we now have really clearly defined areas that we can work our staff from, which actually makes it more advantageous for them. So that should help to close the recruitment gap longer term. Yeah.
So just in terms of reablement, because it's such a key component of all of this, if you look at it from the from the perspective of the individual who's receiving that support, what does your service look like now? What will it look like in the future in terms of the person who's receiving the care?
Well, for me, and Phil and Betty might have a view on this, but for me, it's making it so that it isn't too confusing. So it's, you've got to imagine they're probably in a state of crisis anyway. Some big changes happen to their life potentially, and we need to make this as seamless as possible, their journey through, to get them back into their own home and reablement as quickly as possible. The whole point, of course, is to keep them out of the hospitals and delay their entry into residential care as long as we can. Betty might have a bit more detail there.
Yeah, so I think if I was having reablement now, if I was coming out of hospital, or if I was in the community and I didn't want to have to enter into a different environment, I think what might be true to say, not for everyone, but I'm absolutely sure there would be some people who would say that the delay in getting it is too long. because the delay in being able to get it is too long because there isn't enough of it. So I would probably with confidence say that would happen to some people in the future. What I would hope is that we have enough reablement for everyone who should have it to be able to get it. And that kind of lends itself to what Phil said around you've got to reconfigure the funding. It isn't about additional funding all of the time. It's about reconfiguring the funding from long term into short term, and reablement is short term, and it should have that recovery approach. So if we get this right, we could have a model that gives us all the stuff that we were talking about and that it is fit for the future. And I think what I would just touch on as well, it's around how you make sure that that offer is in reaching into different areas as well. So we have some of our reablement team who are in reaching into our acute hospitals. So we have some OTs who are part of reablement, who are part of our transfer of care hub in our acute environments as part of that MDT. We don't have enough of them, but we're building, and that's what this transformation work will allow us to do as well.
And just in addition to that, sorry, Patrick, is around actually talking Betty talking about there may potentially not being enough of the service at the moment. So a small detail is that we're looking at discharge lounges, so that actually even within the same day a bed can be reconfigured and rehoused, because at the moment, as you point out, it might be a short delay there, and that's just putting more pressures on the hospital. So it's about how quickly can we flow through a place like Coastal Lodge or support people back into their own home.
So I do have quite a good understanding of reablement through my day job, but I do think that it doesn't. If I said to somebody in the street about it, they'd probably have to guess what that really meant. And I was just wondering what your plan is, because I do think it's an interesting shift, but I do think that actually the community, but also people that might want to work in adult social care, would really get that, and they would actually see that in a much more positive, like, I can make a difference way than that idea that they're just going to unfortunately be caring for people as they deteriorate, and there's not really, well, the end point is going into long-term care, which is always a bit sad. So I just wonder how you're going to sell reablement as a job, as a career, and you know what's the progression going to be to offer that, because I do think that if you can do that, I think that would be, you know, you're almost offering a different option, a different job, a different career, aren't you? And it may just be it's a great opportunity to rebadge what you're asking people to do within the job, and that might well help with your recruitment. But I'm just wondering how you're thinking about that. Thank you.
Yes, it's twofold, I suppose. It's advertising it within the system as well. So ensuring that colleagues, social workers, whatever it might be, understand that they have this service arm that they effectively own internally, and that we're there for them to provide the care. So that's the first thing, and Betty's team help out massively to do with that, and Phil on the commissioning side too. But the other side has been a constant evolution ever since I can remember. So it's just about re-advertising, changing your marketing plan, engaging with different communities, keeping in touch with the NHS. We ebb and flow depending on terminology changes as well over the years have been quite stark. So there isn't any magic button, unfortunately. It's become quite clear over the last few years. So we just have to keep it fresh, keep ourselves out there. Budgets are tight, but whatever budget we do, a lot to marketing. We are really focusing on the reablement side, and I think we do see fits and starts. And I think, just alluding to your earlier conversations, I really liked what you were saying about the carer, the holistic carer view. So actually, one thing that we've started to do now, particularly with our employment contracts, is to stipulate that actually, if you become a carer for Tricuro, you will get the training required to work in any area of the business. And I think that's so important, and that's the flexibility that is really, really key to this as well. Is, you might enter as a carer grade 4 in Avon View, but actually your career progression is such that you will end up working as a reablement manager in years to come. And if they can see that career path through, they're far more likely to stay for a career. Exactly that. Yeah.
Good, Councillor Salmon.
So you talked about issues with recruitment and retention earlier on. I'm just curious because looking at you guys on Glassdoor, on Indeed, come out fairly average. You know, not incredible for care, like for the sector. You're not up, you're not down compared to the other providers. What's the rate of turnover at the moment? What's the annual staff turnover?
Didn't turn it off, sorry. So we're seeing about 5%, which I think bucks the trend for the sector. It's actually from memory, and this is data's a little bit old now in my head, but it's about 11% for the sector maybe. I mean, one of the things that I wanted to part from today is actually understand what metrics you would like me to bring. If indeed this relationship continues in the scrutiny board, actually what metrics would you like to see? And turnover, I think, is a really good starting point as to how people see a company.
5% is cracking. I was definitely thinking I'd hear a double figure number.
No. You know, it does ebb and flow over the years, but in the last, and obviously with the changes that are happening, with some changes that will go on in the very near future to some of our services, that will unnaturally increase for a short period before coming back down to a natural position, I'm sure. Also alludes to our, if you're going to ask about our absence rate, is also very low. So we're averaging about 6.5%. Again, the sector is about 8.5%. The last 6 months have been just 4.6 for the whole of Tricuro. I set a rather outlandish target of 4% at this time last year, in the hope that we could really scrutinise our absence rates and bring those down, and we're edging closer to that. So in terms of trying to get more for your money that we're talking about all the time, actually keeping absence rates down, and that's percentage of working time lost to absence.
Thank you. I think at some future point that would be really appreciated, as well as you know, just some statistics on the point which we were touching on earlier about how many people are you seeing. Yeah, you know, how many people are coming through the service? Is it going to, you know, is it going to increase?
So another point that Councillor Salmon raised earlier about the data. So interestingly, my knowledge on this might be a little further on, Phil, just because I'm in the weeds of it back in base. So we actually do have a direct feed on a number of the KPIs that the commissioners request. And actually that means that Phil's team do have direct insight from us on it actually refreshes daily. So what I'm trying to say is we're some way down the line to picking and choosing from the hundreds of KPIs that we have what might come here for the likes of the members to see. I know what you were talking about in terms of the mosaic is the more holistic provider view, and that's what we don't tap into. But actually, if you look at it from the reverse, the commissioners do already have sight of Tricuro as an entity.
Okay, that's good to know. Sorry, Phil.
I just wanted to reiterate, because Joe, you were talking specifically about mosaic, and so yeah, so that feed's going directly to our performance team, quality team, and to the commissioners. So that is great, but then we have to manually upload it into the performance. It's that incorporation, so it becomes an automatic incorporation alongside other services, so that we get a picture. But it's almost it's effectively a data warehouse in one sense, but not in the way that it can then be analysed automatically. That helped.
Yeah, am I right in thinking that's not particularly granular data you get? That is literally baseline KPIs, so it's not individual cases.
No, it goes right down to individual client level data, depending on which service we're talking about. But we get it in a variety of forms. So if it's about who's in residential care, we'll know by individuals. If it's who's getting reablement, we'll know by individuals, because we use it as part of the tracking process, for particularly around hospital discharge, to track the person's journey.
Thank you. Any other questions? Thank you very much, Phil, for your help with that. Nice to hear you. Right, without further ado, I think we're going to move on then, please, to the future of public health in BCP Council. Gillian.
Thank you very much, Chair. This is a follow-up discussion to the previous meeting where we had quite a full conversation about our ambitions for the future of public health in BCP Council, and particularly focused on creation of the role of Director of Public Health and what we would like to see around that Director of Public Health role. You gave me some recommendations to take away and to think about as we continue to shape the role. And this paper is really an update on the thinking there and on the programme as a whole. The shape of the Director of Public Health role, reflecting on the conversation we had and other conversations I've had elsewhere in the council, the proposal I'm working on now and taking towards the Corporate Management Board, which is where the change brief for a director role would be signed off. I've put together a proposal around bringing together public health with community services in a single directorate function. I want to say a little bit more about that connection and why I think that will be value adding and position us really well for the ambition that we have for the future of public health. So community services cover community engagement, community development, and strategic work on community safety. For those of you who were on or watched the Health and Wellbeing Board discussion earlier today, you saw one of the community initiative managers from that communities team talking about work with the Food Safety Partnership. So the communities teams are really the eyes and ears of the council out there listening to communities, working alongside communities, and particularly in priority areas across the BCP Council area. They also do a lot of strategic work with the Community Safety Partnership, which has itself adopted a public health approach to the way it does its work. And you'll remember that in our conversation, we talked a bit about knife crime, and obviously there's other aspects to community safety as well. So bringing together those two functions gives us a real opportunity to make some more connections. Both public health and the communities teams have some similar ambitions, I think. They're both teams that are very focused on prevention. They're both teams that are very focused on tackling inequality. They bring a different professional lens to that, and in public health, our teams will talk a lot about health inequalities, the communities teams will talk about inequality, and of course the two things are interconnected. So I can see some real value add from those. There are some lots of examples out there of functions where there is a director of public health that also leads communities. Bristol has a director of communities and public health, and we maybe get into a discussion at some point about which word comes first. But I'm not getting into that at present. But that's where the proposal currently is. My aim is to advertise that role in September. We're coming into the summer period now. It's not a good time to be going out and recruiting for roles, but we're aiming to do that in September when we come out of the holiday period. Lots of that, as I think I've explained before, is subject to working with the OHID and the Faculty of Public Health, because Director of Public Health appointments are joint appointments with the Secretary of State for Health, and that's really important. So the next stage is some further work with them on job descriptions and adverts and all of that detail we have to work through with the faculty. On other aspects of the work, we continue to have a joint programme board with Dorset Council, which is meeting. There's a lot of really detailed, granular work that needs to be done around the disaggregation of the two services, around contracts, around legal work, around thinking through HR, around thinking through the finances, and that work is just continuing. One of the things that we hope to take a kind of settled view on quite soon is what does it mean by April 2025 to have separated the two functions? What absolutely needs to be in place for us to be clear that we've achieved that goal, which is the goal that was set for us when Cabinet agreed to give notice to separate the two functions, and we will we will pin that down, and then we can really nail down that critical path, that timetable, which is really important for everybody involved in the work, particularly for the staff involved, to know what does this mean for me, and when will things change, and how will I know how it affects me. So we hope to have that settled quite quickly. And from the planning work that we've done, it's already clear, and I think we knew it at the start of the work. We won't have completed the job of creating our future function and really getting the most that we can out of our future public health function by the 1st of April 2025. Doing that in 11 months, we will achieve the separation, and we will have created our own function. But there will be a further phase of ongoing work to be done to really make the most of it. And I hope we can continue the conversation with Scrutiny as we're doing that, and as the process is kind of prompting more thoughts, I think, within the council about the future of public health, and public health in its broadest sense. And I think that's what's really, really interesting, is the conversations that we're having around all of the council's functions and the contribution that they can make to health and well-being more broadly. So that's all I'll say for now. It's quite a process update, but that's the position that we're in.
Thank you, Gillian. I know Councillor Martin's on the screen and would like to say something in a minute. I just want to echo what Gillian has said, though. I think it's been really encouraging to see the debate that's gone on about the reach of public health and how it can interact with so many other aspects of what the council does, to the extent that in all the discussions that we've been having elsewhere about our problems with housing, to look at that from a public health point of view and the impact it has on people's lives is a different sort of perspective. And the fact that people are beginning now, I think, to see that there is a public health role and influencing in a lot of other areas that the council operates in, whether it's active travel or whatever else it is. There is that impact, public health impact in all sorts of things that perhaps we haven't really given enough thought to in the past. But Andy, would you want to say something, please?
Yeah, thank you, Chairman. I'm grateful for this opportunity. I wasn't sure whether it would be appropriate for me to just to say a few words this evening, because obviously Gillian's report is sort of a process report, but I'm grateful that I've got the opportunity to do a bit of advocacy work, if you like. When we went through all the sort of various meetings throughout last year about the budgets, and as we all know, there was something hanging over the cultural budget, because arts and culture is not statutory, as we know. One of the most powerful arguments that we were able to use in persuading colleagues that we needed to retain the cultural budget was not so much about the value of the organisations and what they do on the stage or on the dance floor or in the community in performances, but actually the amazing work that our grassroots cultural and arts organisations and our national portfolio organisations, for example, do in health, well-being, and I would add happiness to the end of that. So my plea is, and I've spoken to Gillian with Gillian about this several months ago, is that in this process of as we go on this journey towards creating public health BCP or whatever it's going to be called, that we put arts and culture at the heart of our thinking, or certainly as part of the heart of our thinking, and understand what you said about housing and transportation and other aspects of health and well-being that maybe we haven't looked at previously or haven't been central previously. And if I can just give a couple of examples. So, for example, Pavilion Dance Southwest, they do amazing work in communities, and they do fantastic work with Parkinson's patients, for example. Arts by the Sea Festival, outreach work in some of our areas of deprivation. The Bournemouth Symphony Orchestra in issues like in care homes, in hospitals, and the people in hospitals are our patients, and the staff are our residents, and things like dementia and Alzheimer's. And then Beef, the Boscombe Emerging Arts Festival, amazing work with recovering addicts and refugees, etc. I could go on. I have a whole list of those. I have lots of metrics and analytics about what they do, what this community work does in terms of health and well-being. And I, as I said, I feel that arts and culture really must be central to our thinking as we progress our policies and strategies. I've had a couple of really good conversations with Arts Council England, who are very excited by us taking this approach, if indeed we do. And I've also had a meeting with our national portfolio organisations. That's the 5 big fund organisations that we fund in conjunction with the Arts Council, and they also are very keen to be involved in these discussions and offer their input as to how they can help in our health and well-being strategy. And the final point I would make would be, as you talked about the recruitment of the Director of Wellbeing, Director of Public Health. Sorry, Gillian, I didn't mean to suggest that we need a replacement for you. Quite clearly not. The Director of Public Health, that person hopefully would have some significant appreciation of the role that arts and culture can play in health and well-being and happiness. And my final point actually is there is such a wealth of information about this very subject by the Arts Council, by National Health Service, by parliamentary select committees, all outlining the incredible work, the incredible power of arts and culture in health and well-being. So I'll leave it there. I'm very grateful for this opportunity, and I hope we can continue these conversations. Thank you, Chairman.
Thank you very much for that, Andy. I was surprised, but really pleased to find out recently, because I attended a performance of a play called Wasp's Nest by a charity called Vita Nova, who work with recovering addicts at the Black Cherry in Boscombe. Really pleased to find out that actually the public health had supported them with some funding in order to be, able to do that kind of work. So that was really encouraging. Any questions? Any points anybody wants to? Councillor Waite.
I am probably ignorant on this because, as you know, I was a substituting this evening, so bear with me. But I remember when the conversation was had several months ago about, sort of justifying BCP having its own Director of Public Health rather than sort of sharing with Dorset. And somebody said, well, we've got so many thousands of residents, there's definitely a job for them. And it was almost like it was very much a full-time job already compared with what other directors of public health do. And I understand it, I may be wrong, as sort of like a statutory position, almost like being the Section 151 officer. It's not about getting into, dreams and ambitions and arts and culture and nice stuff. It's very regulatory, statutory, isn't it? So I mean, is this role kind of drifting? Is it because a lot of the things that Andrew was just talking about sounded more like a wellbeing brief than a Director of Public Health, or maybe I misunderstood where you were coming from. But
yeah, it's a great question, and we had a bit of that discussion at Scrutiny last time, and I think the steer was the Scrutiny you were open to seeing a role that was broader than just the core Director of Public Health role, but let's not take it too broad, as some councils have. There's actually a huge range of different Director of Public Health roles now across the country. Some sit at the corporate level on corporate management boards and have big kind of operational responsibilities on side. It varies hugely. You're absolutely right that there is a core set of statutory responsibilities that the Director of Public Health holds. It is a joint role. They do report into the Secretary of State for Health. Much of the grant funding that is provided to us as a Council for Public Health, there are mandated requirements that the Director of Public Health has to assure themselves on the Council's behalf are being carried out. And so, yes, we mustn't lose sight of in the ambitions that we have around public health for those core responsibilities that will remain really important. but at the same time, something that other councils have done, and one of the reasons I think that was the ambition in BCP is to say, but actually public health approaches, ways of thinking, approaches to data and analysis can be applied to other areas, and they can have a bigger impact. I mean, one of the discussions we had as well is that you can connect public health to almost everything that the council does, but at a certain point. And we don't need to create a hierarchical structure where the Director of Public Health takes over everything hierarchically for them to influence, because of course they can influence across the council, and the connections into culture. Definitely, I can see definitely into active travel as well. And of course, they'll have to operate across the council in the sense that we're recruiting them into the Directorate for Wellbeing overall. But they'll have to also work across children's services, because a lot of the work of public health is also with children. So, yes,
so if I were in the market for this kind of job, it wouldn't be like a really, wacky job description. It would be the kind of thing that people would be used to doing, and it's just a case of work across all our departments and work within our culture, and that's something that a prospective candidate would be able to take into their stride, I suppose. Is that fair to say?
Yeah, an expectation we would have for all our directors and indeed our heads of service, I would say all our senior staff across the council, is the ability to work horizontally across the council, and the DPH role will have to do that particularly well.
I think the department might have something to say if we made the job description too fluffy. Any other points on? Oh, Councillor
Allen. Since I was elected, I've been strongly advocating for us to have our own Director of Public Health, and I'm really delighted that that's the direction that the council went into, particularly around commissioning services that are particularly needed for some of the big issues that we have, particularly in our conurbation. And I'm thinking of drug and alcohol services particularly. However, there is benefit for working with Dorset, and I've seen the benefit of that again in my day job. Although I always felt that we should be commissioning our own services, and I was worried that actually it would get watered down if it had gone in the other direction. But I'm just wondering what's your thoughts around that, because I can see the strong benefits, but I can see that it's really important that we don't lose that county-wide view as well. Thank you.
Yes, I absolutely agree, and we've been clear from the start of this process in Cabinet's consideration of the issue, in all the discussions we've had with Dorset Council since then. We will continue to be a part of the Dorset integrated care system and to play our part within it. There will be places and issues where it makes absolute sense for us to work collaboratively. There will be some issues where we can share and learn from each other. I think some of the work Dorset's doing around their ageing population is something where we want to continue to work really collaboratively with them around. I'm really encouraged that in the discussions we've had with Dorset Council since Cabinet gave that notice, it's continued to be a really collaborative process and discussion. And we're talking not in terms of we're talking in terms of what's the new relationship of partnership that we have to have in the future, and how can we learn from other systems across the country where there is more than one Director of Public Health, sometimes 3 or 4 in different councils, and how can that bring benefit in systems rather than disadvantage. But it's a really important aspect of the future planning, is thinking about that, the new partnership, I would call it.
Okay, everybody happy on that? Can we move on? Okay, we've got a couple of items which are for information, but I kind of dropped Betty in it by saying that certainly in relation to the maternity paper, if there were any questions, that we would gather them in and get some answers for you. I have rather cheekily sent some today, but Councillor Moriarty.
Thank you. On page 104, I think it was talking about the fact that as we know, maternity services are very, there's disproportionately more ethnic minority groups and lower socioeconomic families who are disadvantaged by the system. I'm probably not saying that very well. It talks about the national picture. Do we have any data for the more local picture? Because I think that will be quite important to tease out.
With regard to the maternity paper was kindly produced by our colleagues in UHD, Universities Hospital Dorset, at the request of the chair and a request in the paper to come to this committee. So it would be unfair to try to answer any points. But what we have agreed, and we were speaking just earlier this afternoon to Siobhan, who is the chief exec of UHD, we're very, very happy to put any questions to Siobhan, who will in turn direct them to her right director, and most likely the director who wrote the paper. And then the questions will come back to the chair, and then you can consider what you would like to do as the next step. And what I would say, our colleagues in UHD are very happy to come to committee and to share those answers, or to come and explore further on any aspect of those. So I have had a number of questions that have been put, and your question is very much along the lines of one of those. So I'm very happy for your any member to put their questions to the chair, who in turn will make sure that I receive them all. And we have opened the same offer to, you can see Councillor Brown's behind, to Councillor Brown in the role of chairing the Health and Wellbeing Board earlier today, because the same paper went there for information. But can't reinforce enough, our colleagues in the hospital are very, very keen to share and for overview and scrutiny to play a role in whatever papers, whether what they produce, either for information or more for discussion and scrutiny. Yeah.
So there's an open invitation there, not like even now, but if you haven't read the paper, if you think of questions that you would like to raise, please just let's have them, and we'll do our best.
We will absolutely do our best, but can we have a cut-off time? So please, so maybe, I don't know what's reasonable. What would you consider reasonable to have the questions to you? But if we have some parameters, that would be grand. Thank you.
What day of the week is it now? Yeah, within a week, perhaps. Yeah.
Can I just make?
Yeah, that's it.
I just wanted to make a comment that in 2022, the service did not have enough midwifery or medical staff. Now, midwifery vacancies are at 0%, and that's absolutely fantastic. I mean, what a difference. So just a congratulation that even that figure is really well done. Not a question though.
Yeah, and I will feed that back, and I think you'll note in the paper that was when CQC had gone in and they had put some really clear fundamental changes and an action plan in place to bring about those changes. So yeah, I'll feed that back. Thank you.
Yes. So as I say, if you think of any questions, just please let us have them. So the other paper for information was on the adult social care charging policy additions. So any points on that?
So, yeah, this is a paper that we put together. It is a very lengthy paper. I sought some guidance from our monitoring officer around whether or not it needed to go to full council, and it doesn't. It needs to go via this route and to cabinet. It will go to cabinet on the 17th as well. What I would say in that changes, and you should have the two appendices that show you what it was and what it is now. And the reasons for that is it's all centered around disability related expenditure, which is when you're undertaking a financial assessment to ascertain somebody's contribution towards their care, you can take into account particular things that they need for their daily living. And that can fall under disability related expenditure. Can either be a piece of equipment, it can be something that will help them have a better quality. And within our current policy, which is the policy that we work to now, we felt that we needed to tighten that up a bit, and to the benefit of the individual. And there has been some legal challenge elsewhere around the for charging policies that councils, one or two councils might have. And if you like, this is us being able to get ahead of that. And there potentially could be that potential, I guess. So not huge amounts of changes. If I'm being honest, in the scale of the policy, it's very hard to find them. That's why hopefully I did highlight them. I intended to highlight them in yellow. I know I did, but sometimes it doesn't come through when you. So yeah, just look at those changes. It is to the benefit of the individual to make sure that we're not inadvertently missing anything that should be considered when the financial assessments are undertaken by the financial teams within another area within the council.
Any immediate questions on any of that? Okay, we're doing really well. So we're going to move on to the forward plan. Now, at this point, I just wanted to give a little bit of a feedback about the work planning workshop that we had a few days ago. So what we were looking at was the ways in which we are going to try and do scrutiny going forward. So one of the things that was suggested was that we needed to look at the work we do on scrutiny through a particular lens. And we were discussing what kind of lens that was. And what we felt was that should be a lens based around service user access. So an experience of services and care. And I think officers supported the view and felt that there was a potential to bring some value through scrutiny work. So it's about a suggestion of the wording of equality of access to person-centered integrated care as the lens through which we're going to try and look at the work that we are doing. So that was one action that came out of it. I'm just going to run through the others and then I'll pause. So the next one was about the idea that of kind of separating out the sort of items that we've just discussed, which are purely for information, to try and keep us as informed as we can. But by having taking those out and having separate teams-based briefing meetings, kind of in between the normal cycle of our ONS meetings, and these will just be teams meetings, which will be briefings on issues which come up from time to time, but are just for information, and as I say, just to try and keep us informed. So we will try and find a sequence of dates to do that, but that's the recommendation or recommended action. So the other thing was, in terms of looking at the work we do, I was just asked to draw your attention to this document, which has been circulated. It's the key lines of inquiry document, and if we are looking at things that you want us to look at in terms of overview and scrutiny, that you do that with looking at those key lines of inquiry and setting out what you think they should be. So if you think of if a particular issue that you want to look at, then that is the document that you need to refer to. So that would apply, to the kind of the maternity paper that we've just looked at, but that again is a kind of tool, if you like, through which we want to try and process the work that we need to do. So the other thing came out of that meeting really is quite a long list of items that are topics that we would quite like to have a look at. Very long list, in fact. And what it was felt that perhaps what we should do is we'll set out some kind of consultation with the committee about what those items are, what you think are pressing, where you think their priorities are. So we'll do, if you're happy, we'll do that consultation on that long list of topics. Encourage a response to come back, and then we'll have another look at the forward plan. Bearing in mind those preferences, those desires to look at particular subjects. I'm sure we've all got different ones, but somehow or another, we will find our way through that and look at the priorities that we want to address. So those were the kind of recommendations coming out of that committee. I'm just looking at Louise to make sure I haven't forgotten anything.
Yeah, just to make sure that the rest of the committee are happy to kind of progress those actions.
Yeah, is everybody happy with that? That's great. So there is the forward plan as it stands at the moment anyway. So you'll see that next meeting is not until September, but we'll be having a look between now and then at what, based on the feedback that I've just referred to, what items you think need to come forward. And also, hopefully before then, we will have sorted out a timetable to look at those team briefings on information items just for information rather. Okay, is everybody happy with all of that? Okay, so if there is, go on.
Sorry, Chair, you just missed out the portfolio holder update for Councillor Brown.
Councillor Brown, how could I do that to you? My apologies. Councillor Brown, portfolio holder.
No, well, I won't delay you long. It's only be fairly brief. To be honest, actually, a lot of the work I've been involved in over the last couple of months it's very much around the items that are on your agenda this evening. So very much around the future of public health, the adult social care transformation business case, which goes to Cabinet this week, and also Tricuro. Attended a Tricuro board meeting a couple of weeks ago, and also we've had other shareholder governance meetings with Tricuro board members, which have been really useful actually, I think, on both sides for myself and ourselves, and also I think for the directors of Tricuro and the non-executive directors and the interim managing director that they've got there. So yeah, we've had some really useful sort of conversations and in exchanges with Tricuro, and I'm quite positive actually coming out of those about there's a lot of change going on with Tricuro and implementing sort of day opportunities changes. It's a challenge for them, but I think we've got the right people there that are really sort of stepping up to dealing with that. So yeah, those that you've had updated tonight. A lot of what's been going on the last couple of months. I must admit, on reflection, it's been nice to sort of move on from 9 months or so last year into this year, very much focusing on budgets and finance, and now we're very much looking at service improvements, service structures, partnership, working with the NHS, those sorts of things. The real, things that will make a difference to people's lives. So the last 5 or 6 months, it's been quite nice to have that sort of shift of emphasis, really. One other thing to note, I attended an adult safeguarding board learning event on the 20th of June. Quite a few colleagues were on that as well. In some ways it sounds quite dry. It was a learning event about serious adult safeguarding adult reviews, the SARS, and learning that's come from this sort of incidents and cases, both locally and sort of national cases as well, which we've had back. It was facilitated by the Dorset and BCP Safeguarding Adults Board. there were in excess of 450 people on that Teams meeting of our staff, but also people from Dorset Police, people from the fire service, lots of people from the NHS. And it's a massive investment in time. It's about a half-day training session when you've got 450 odd people attending that. But on reflection, it's sort of, if we can change people's practice and improve things that we avoid those sort of serious cases, then it's worth every minute that you spend in those sorts of training sessions. So that was a really useful and informative learning event. And then today we had the Health and Wellbeing Board, as you attended this afternoon, and very much looking at all the sort of health, working really in partnership with our health service partners, looking at integrated neighbourhood teams, looking at the changes in University Hospitals Dorset, the maternity changes, and it's pointed out now that these have been talked about for a long time, these changes to the local health service in probably the last decade, and I think we've probably all been around when there's been controversy over them and lots of discussion and debate and public comment on it. And to suddenly think within the next year or 18 months these are going to be coming to fruition, it suddenly sort of focuses the mind that actually next spring the maternity unit is going to be there at the Beach building. So actually, if you're getting pregnant now, in your 9-month project plan, you're going to deliver in a different place to where you would have been. So, yeah, Bournemouth rather than Poole on the birth certificate. So that's the first bit. But then there's the emergency department side of things and the elective surgery side of things between Bournemouth and Poole Hospital. So I think that's really going to impact on our sort of social care provision and working with the health service, and it's going to impact on residents right across Bournemouth, Christchurch and Poole. Any kind, if they need to go to A&E or if they need elective surgery, hip operations, those sorts of things, it's going to mean changes for everybody. And I think just to realise that that's coming in the next 18 months is quite important to keep a focus on. And other than that, we've got integrated care partnership meeting next week, again working with our partners right across Dorset. So yeah, there's a lot of interesting work going on.
Thank you. Any questions from the committee? Okay. Oh, Councillor.
Are you concerned about any of these things? Is there anything coming out from the conversations you're having, particularly about the fact that we've all been talking about this hot and cold site and the way that care is going to be delivered in secondary care for feels like forever. But now it's starting to, things are moving. The treatment investigation units moved to Poole. Some of the big moves are starting to happen now, and I just wonder whether you feel that from a council point of view that there's anything that you're concerned about, any risks that we need to be aware of that we need as a board to have eyes on, because I know there's always great planning, but there's often still things that maybe fall through the cracks. Thank you.
Probably in terms of concerns and risks is making sure and that's part of what comes down to the adult social care transformation, is making sure our services are in the right place and the right structure and delivering in the right way to actually match with the changes that are coming on the health service side. And one thing which people haven't talked about much is the change in bed numbers across between the two sites. This is going to be quite a substantial reduction in bed numbers. And we need to be able to work with that in terms of ensuring people are discharged promptly and all those sorts of things, because the part of that project is reduction in bed numbers, and it'll be no good getting there and suddenly thinking, well, hold on, we've got all these people and now we've only got that many beds, what are we going to do? We need to build a new care home and push people out there, or you can't do that. So it's very much working with our partners to actually make sure that actually works when that transition happens, and make sure our services are working hand in hand with the health partners to do that. So I suppose that's an area of concern, because it's a major change that is coming down the line. We know it's coming and it needs to be sort of properly planned and prepared for. So.
Thank you. Any other questions from Councillor Brown? David, thank you very much indeed for that. Very much appreciated. And I think Gillian wants to say something.
Yes, Chair, just one final thing before the meeting concludes, which is I need to share some sad news, which is that Phil, our excellent Director of Commissioning, is going to be taking early retirement at the end of September, very early. Yes, I can see that people are shocked, extremely early.
I've only just left school, Phil.
And so this will be his last of, I'm sure, many meetings with Scrutiny after 31 years working in local government, 11 of which in BCP, and before that the borough of Poole. So an establishing member of the BCP Council team. And I want to give particular personal thanks to Phil for all the support and advice he's given me since I joined BCP Council last October. I've learned such a lot, although hearing him talk in the discussion earlier alongside Betty about our ambitions for adult social care transformation just made me feel how much I still have to learn. But we have 8 weeks, Phil, so you can pass on some of the knowledge. And I did hope, hearing you talk, that maybe you might have changed your mind, because the future is looking really interesting. But I know your future is looking really interesting too, and you have other things that you want to do. But I did just want to take the moment to share that news with the committee.
Thank you very much, and thank you, Phil, for everything you've done to help us through this process. Okay, I'm going to close the meeting on that acclamatory note. Thank you very much indeed.